Okay, so good evening and welcome everyone to the 13th edition of Legendo. Lister Endometriosis Journal Club is a virtual journal club with a difference. The idea is that we will try and present what has come out in the last year or two in a very concise manner without going into too much detail. But we choose one, sometimes two featured articles and ask their authors to come and present their work. Um, this week, Mr. Holland and Ms. Bailey are going to present their work on diagnosis of superficial endometriosis on transvaginal ultrasound scan, which we will hear a little bit later. But some housekeeping first. First thing to say is that this is thanks to the support and help that we get with the running of it from Karl Storz UK, but we don't or haven't yet received any financial support. And also that it's a joint venture with the European Endometriosis League, and we're very grateful for their support. We, as the people running this, the CMIG London team, don't necessarily agree with everything that is said on the journal club, but we choose papers that have something to say and they're interesting, and we think that it would be noteworthy and it would be interesting to listen to. Legendo happens on the 6th of every month at 6 p.m. UK time, and we're hoping to be able to continue running these. If you have any suggestions, if you have any papers that you've seen published recently and think would be worthy of a presentation or maybe even being a featured article, please get in touch with us. You can see the Legendo team, which is the same as the CMIC team on your screen. Avril Bachi, Ben Mondelli, Mikey Adamczyk, Florence Britton, and Kyle has sent his apologies. Okay, so the format usually is that we start by presenting a couple of the smaller articles, and usually two of the team will do that. Then we'll go to the featured article, and then we'll go back to a couple of other small articles. If you have questions, you want to say something, please use the Q&A box, and one of us will pick up the question, and hopefully if there is time we can discuss that. Avril, I think you're first, aren't you?
Yes, thank you, Mr. Kazali. So the first paper that I will be talking about is a study by the team from Italy. And this is actually the first study looking at the different directions of closing a posterior vaginal wall defect after opening it for rectovaginal endometriosis. So this is a multi-center retrospective cohort study. They included all women who have had rectovaginal excision, endometriosis excision between March of 2013 to December of 2018. And they divided these patients into two groups. So there were 67 patients in the horizontal closure group, and there were 34 patients in the vertical closure group. And the outcomes they were looking at were complications, pain symptoms, and recurrence. So in terms of statistically significant results, what they found was there was a higher incidence of Clavin-Dindo grade 3 complications in the horizontal closure group, and there was more consistent improvement in pain symptoms in the vertical closure group. There were several limitations to the study, including it being retrospective, small sample size, some bias with the surgeon choosing who had a vertical closure or who had a horizontal closure, and also that they did not have data on the length of the vaginal wall before and after surgery to have strong evidence to support the hypothesis for their results. So this is a bit of the background. So the table here on the left is the baseline characteristics. As you can see, it is similar in both groups. And on the right side is the surgical data. Um, in terms of the combined vaginal approach, this was employed more on the horizontal group where the author said that they delineated the vaginal nodule vaginally first before proceeding laparoscopically. There was a higher incidence of laparoscopic vaginal suturing in the vertical group. However, the authors did not make any comments on why that was the case. This is to show you that the severity in both cases, both groups were similar. For example, the amount of bowel procedures done in both groups as well. There was no significant difference. The size of the vaginal nodule as well, mean size of 2.2 centimeters in the horizontal group and 2.4 centimeters in the vaginal group. In terms of complications, there was a significantly higher grade 3 complication in the horizontal group. In the vertical group, there was one incidence of rectal perforation, whereas in the horizontal group, two cases were due to ureteric injury where they needed to return to theater for stents, one rectovaginal fistula, one dehiscence of the vaginal suture, and one rectal perforation. In terms of follow-up, there was no significant difference in the follow-up for both of the patients. But as you can see in the pain symptoms, the vertical group, their scores were very consistent with all of them scoring 0 after the surgery. Um, and then in terms of recurrence, there was no significant difference in recurrence for both groups. So the authors then concluded that with the horizontal direction of suture in posterior vaginal wall defect, this is associated with higher incidence of post-operative complications, whereas in the vertical direction of vaginal suture, there was more improvement in the pain symptoms. And that's it from me for this paper.
Um, Avril, can you just remind us what was their inclusion criteria,
Um,
roughly?
so their inclusion criteria, so they just mentioned that all women who had rectovaginal endometriosis excision between this time period.
Yeah, but rectovaginal and opening of the vagina for whatever reason,
Yeah.
obviously. Yeah.
They didn't mention specifically opening of
Because
the
if you
vagina,
look
but I
at,
can assume that.
yeah, but well, it must be, otherwise,
Yeah,
what's
why
the
would you put
closure of
a
the vagina?
suture? Yeah,
But if you look at the table on the right, then
this
what,
one.
yes, then look at associated surgical procedure. So it actually does not include hysterectomy for many of them. So only two of those 67 had a hysterectomy.
Mm.
So I'm a bit unclear about what they're talking about. So is that a partial or mostly partial vaginectomies that they're talking about? So it is the closure of vaginal defect,
Yeah,
partial
because
vaginectomy is the title.
yes, because in
Go
here
back to the title of
because
the
in here they put vaginal nodule, so it must be
uh,
excision of the vaginal nodule.
okay. So they're
Avril, do
And
saying
you know
this is
like
the
how many
title.
operators?
posterior vaginal wall suture after eradication of rectal. So
Yeah.
yeah, it looks like a partial vaginectomy. Is that what you
Yes.
think then as well?
Yeah, but like I said in the methodology, they said all women who had rectovaginal endometriosis excision.
Mm.
Mm.
Okay. Well, that's interesting. We always do vertical. What makes it even more interesting is that they were able to, in multi-central,
Mm.
in many centers, they were able to go back and figure out if somebody closed vertically or horizontally.
Mm.
And,
Yep.
and was that, the same surgeon always doing the same thing, or was it a
Mm.
surgeon then doing different techniques? Um, my problem with this type of study is that unless you have a very logical explanation for the relationship, it can become a little bit, I don't know, illogical. You can say the relationship between Clavian 3 and the
Mm.
temperature of the day outside, and then you may
Yeah.
find something. Why would a vertical or a horizontal closure make a difference
So
unless
what
the
they inference was possibly that the horizontal suture shortened the vagina length, and this created more tension in the vaginal sutures that could lead to the higher risk of complications.
Mm.
Although there is no large defect because you see the nodule is around 2.4 centimeters. So
But not just that. When you look at the actual complications that they're talking about rectal
Perforation.
perforation.
yes.
Why would the direction of
Yeah.
vaginal suture change
Mm.
rectal perforation? If it was just the fistula, I could understand that to some extent. Or, all right, maybe ureteric injuries can happen more if you suture horizontally. I don't know.
I can pick
Anyway,
that.
yeah, what do you think, Mikey?
Yeah, I think it's a bit of a grey study.
Yeah.
I agree. I don't quite understand all the complication rates. I can
Yeah.
kind of get the pain scores. Okay, maybe it makes sense with tension wise. Other than that, yeah, interesting food for thought.
Okay, thank you. And Flo?
Thanks very much. The paper that I'm going to present was published last year in 2023 in Fertility and Sterility, entitled Efficacy of Acupuncture for Endometriosis Associated Pain, a multi-center randomized single-blind placebo-controlled trial. So just a bit of a background, acupuncture has been used for many decades on pain management, but actually in the current literature, the amount of research that's on endometriosis-specific pain is pretty scarce. Earlier last year, in one of the earlier legendos, I think it was Mike, he did go over a systematic review for acupuncture, but I thought this would be interesting as this is probably one of the largest RCTs out there for acupuncture, but you'll see that still the sample size is a little limited. So moving on to methods, it was a multi-center randomized single-blind placebo-controlled trial, and this was carried out in China across 4 different tertiary hospitals. You can see on the flow diagram there was 566 patients selected, and then with the various inclusion-exclusion criteria, there was 106 eligible for the trial. And then these patients were randomized to receive either acupuncture or the sham acupuncture. The treatment lasted for 12 weeks and consisted of a 30-minute acupuncture session daily for up to 3 times a week in the week leading up to menses. And then when they were menstruating, so long as they were having pain, women could have it daily. So they had that for 12 weeks. And then after cessation of the treatment, they were then followed up for a further 12 weeks to assess their outcomes. So the main outcomes for this study were the changes in maximum pain assessed, and that was assessed using a visual analog score, the duration of the dysmenorrhea, and then scores on various pain and health-related scales. And then it was these measures that were evaluated to look at the efficacy of acupuncture. So the study group concluded that it was actually effective and safe for relieving dysmenorrhea, for shortening pain duration, and for improving quality of life based on the questionnaires. And you can see on the graphs that the VAS score for dysmenorrhea, there was a significant reduction in the acupuncture arm compared to the sham. But actually looking at non-menstrual pelvic pain and dyspareunia, there wasn't any significant difference. The study group also said that actually with cessation of the treatment at 12 weeks, any benefit, any significant improvement discontinued at that point. They said that there was no severe adverse events recorded in either arm. So there were limitations to this study. It only looked at women aged between 20 to 40, which does limit the generalizability of the results to other age groups. As I said, it is still relatively small at only 106 participants. And it only followed up these women for a pretty short amount of time, only 24 weeks. So we can't comment on what the long-term effects of acupuncture are. It was single-blinded, so the acupuncturist obviously knew if they were delivering genuine acupuncture or sham. And also it was a placebo-controlled trial, so it didn't compare acupuncture to current standard treatments of endo pain. So conclusions to the study. So it showed that it did reduce dysmenorrhea. It shortened duration of pain. And according to the questionnaires, it did improve well-being and quality of life. But it's an area that needs a lot more research to evaluate the efficacy and safety. We need larger studies, RCTs, and meta-analysis of them to really conclude whether it is effective. The studies need to be over a longer period of time. And also we need comparative studies comparing it to current standard practice. And that's all from me.
Flo, do you know what acupuncture did they use? Was it Western acupuncture or Chinese one?
Chinese in various,
Okay.
in various different acupoints, and then the sham acupuncture, they just use different non-acupuncture points and just put the needles in less deep.
Okay. So that's quite interesting. What makes it more believable for me is the fact that the effects are very different in the dysmenorrhea effect as opposed to other pains of endometriosis. So the authors are not claiming that this helps with all sorts of pain. It has only helped with the dysmenorrhea pain. But what other thing that I wanted to consider is with treatments such as acupuncture, there is always, with all treatments, you can say that about everything. The self-selection of the group that goes for the treatment matters. So they offered this to 480 patients and ended up with 100 patients who, for one reason or another, wanted to have acupuncture. So this is the group that already has some belief in this is going to work. Okay. Now, of course, the randomization is supposed to account for that effect, but still, I think it's important to note that maybe the size of the effect we see should be interpreted with caution. But yeah, that's interesting. Therefore, we can conclude that acupuncture can help with your pain, mostly period pain, but only when you are receiving it. When you stop it, it will go back to the previous levels. Okay.
I think you, Mikey, presented something similar last year, and they show like positive results as well, isn't it? Another study.
There's a lot of Chinese papers on it, mostly actually from China. But I'm a big believer in acupuncture. I like it.
Okay. Okay. So with that, I think it's time for us to introduce our featured article. Mr. Tom Holland was supposed to be with us, but I think something must have happened. Maybe his link doesn't work. Anyway, I've texted him. But Frances is going to present her work. Frances is an obs and gynae trainee in the UK and has taken a year out of program to do some research. And during that, she has worked with Tom, who is one of few people who is very skilled in picking up endometriosis. And this paper is about taking that a step further and asking the question and answering it, hopefully, whether we can actually get an idea about superficial endometriosis and can we use ultrasound scan to diagnose superficial endometriosis. I was very interested in reading the article about the results, and that made me very optimistic. So Frances, please.
Okay, so let me just get this started. So thank you very much for everyone for inviting me to talk, and hopefully you'll find this interesting. So we've recently published this as a paper, so it's focusing on the diagnosis of superficial endometriosis using routine transvaginal ultrasound scan by introducing a technique to look at the peritoneum of the pouch of Douglas in particular. And this was published in the January edition of Ultrasound in Obstetrics and Gynecology. So the objective of our paper was to determine whether we can detect superficial endo on transvaginal ultrasound scan. And we're doing this because we know that about 80% of our patients have superficial disease, and we want to try and further facilitate the new ESHRA guidance, which essentially is bringing imaging in as part of our assessment and diagnostic tools for our patients. And it says that we should still be offering a laparoscopy in patients with symptoms of endo, but with the absence of disease on MRI and transvaginal ultrasound scan. And obviously this is particularly our group of patients with superficial disease. Now, there have been other works in the area here. So Matthew Leonardi, who works over in Canada, has introduced a technique called sonopodography. And this differs slightly in that this involves installation of saline into the pouch of Douglas through a Hycosi catheter to essentially demarcate the peritoneum and the surrounding structures, which you can see in the bottom pictures here. So on the left-hand picture, we have no free fluid in the pouch of Douglas, and the peritoneal surface is dotted out because on a 2D image we cannot see that demarcation. But when we're scanning them dynamically, you can see this peritoneal surface moving with the bowel moving over the top. However, you can see on the right image, so this is a patient of ours who had physiological free fluid in her pouch, that you can see the peritoneal surface is much smoother and easily defined. The difficulty with this technique is whilst it has very good sensitivity and specificity, it is invasive, and he's doing this in patients after they're anaesthetized prior to their surgery to help guide his surgery rather than in an outpatient setting. So what did we do? So we ran a retrospective diagnostic test study out of Guy's and St Thomas's, which is a tertiary endometriosis centre. And we collected all patients who had an specialised transvaginal ultrasound scan, an assessment of their pouch of Douglas, followed by a laparoscopy for suspected endometriosis between April 2018 and September 2021. And then we compared their laparoscopic findings as the gold standard with what we had found on their ultrasound scan. So when we're doing this ultrasound, it's just a picture down here in the bottom left to show where we're placing our probe. So we're using a routine high-frequency TV probe, but instead of placing it in the anterior vagina, for this part of the assessment on the scan, we move it into the posterior fornix of the vagina. And this gives us the peritoneal surface and the vaginal muscle directly overlying the probe, so we can see this very clearly. And we then track the probe back and forth, left to right in the longitudinal plane to make sure that we can visualize the whole peritoneum. What we're looking for are these hypoechoic lesions that you can see in the top right images, which we are then measuring in 3 planes. And you can see here how we're measuring their depth, looking at the old classification of superficial endometriosis of less than 5 millimeters. And then when we're comparing this laparoscopically, we are comparing it to all these different types of superficial endometriosis, and all imaging was images from the surgery were reviewed during the study to make sure that we agreed with the classifications of the surgeons. So very conveniently, we ended up with 100 eligible candidates after excluding 2 because their records were unavailable, and 3 women who were actually incorrectly coded and had laparotomies instead of laparoscopies. And their mean age was about 35 years. 5 patients had physiological free fluid. 3 of them had no endo, 1 had superficial and 1 had deep disease, so that it didn't have an impact overall on our results. And 84 of these laparoscopies were performed by endometriosis specialists. We also looked at their symptoms, and we found that dyschezia and dysmenorrhea were the only 2 symptoms that correlated with whether we actually found endometriosis at laparoscopy. So of all of our patients, 43 patients out of the 100 had no endometriosis. 33 of them had superficial endometriosis, and we detected this with a sensitivity of 51.5, but with a specificity of 94%. 24 of our patients had deep endometriosis, and that sensitivity was higher at 83% with a specificity of 97. We also then had a look at the location. So we were most successful at detecting our superficial endo in the pouch of Douglas with a sensitivity of 50%, but a specificity of 96. And 10 out of 14 lesions identified at scan were confirmed at the laparoscopy. The uterosacral ligament disease was seen in only 1 out of 11 patients, and superficial endo of the pelvic sidewall was only seen in 1 out of 50 patients. We also found that most superficial endometriosis at laparoscopy was actually demonstrative of multifocal disease. So of 90.9% of the cases with superficial endometriosis in the pouch of Douglas were actually found to have widespread disease in their pelvis. And this bottom picture here is just a picture of a uterosacral ligament. So I don't know if you can see my mouse, but this is essentially the trend of a normal uterosacral ligament here, nice and smooth. And you can see here in the sagittal and longitudinal planes that we have this nodule of endometriosis that breaks them. So why is our research important? So we've shown that we have a high specificity which gives us a low false positive rate in the detection of superficial endometriosis. So we have, if a patient has a positive scan, then the diagnosis is likely to be true. However, we also know that 50% of our patients with a negative scan may have endometriosis. So how can this be used in practice? So in practice, if you have a positive scan, you could say to someone the likelihood of you having superficial endometriosis is very high and offer them medical treatment prior to having surgery, or they may wish to delay their surgery to a time when it's appropriate for them, such as could be timed with fertility or ending their family. Equally, if you scan a woman and you cannot see anything, then we now know that in our clinic, we're able to say to people that if their symptoms are significant enough, there is still a 50% chance that they may have superficial disease at a laparoscopy, and it can help with that decision-making for the patient. We've also shown that assessment of the pouch of Douglas peritoneum can also improve the sensitivity of transvaginal ultrasound scan in increasing deep endometriosis. And we're comparing this to previous studies which have looked at deep endometriosis diagnosis on an ultrasound. And we can also compare this and show that this does not affect the specificity, so we're not increasing or giving false negatives or false positives. And then finally, that if we identify superficial endometriosis in the pouch of Douglas or the uterosacral ligament, then actually this can be indicative of further widespread pelvic disease, which may be helpful at laparoscopy in anticipating what we're going to see and need to manage. Obviously, we had some limitations, so this was a retrospective study, so it was not blinded. All surgeons had access to the ultrasound reports, and 50% of the operations were performed by the same surgeon that did the ultrasound scans. We did have a mixed group of surgeons, however, 84% were done by endometriosis specialists, and there was some difficulty with operation note terminology and locations modules, which is why all surgical pictures were reviewed by our team during this. So in conclusion, we can show that detection of superficial endometriosis in the pouch of Douglas by assessment of the peritoneum is possible with high specificity using routine ultrasound scan, and it can facilitate non-invasive diagnosis for a larger group of women than previously. We've also shown that detection of superficial endometriosis in one location may be a marker of more widespread disease, and the absence of superficial endometriosis on our transvaginal ultrasound scan does not indicate the absence of disease. In reality, 50% of these patients may still have disease on laparoscopy. And finally, assessment of the pouch of Douglas peritoneum as an addition to the routine ultrasound protocol for assessment of endometriosis can increase the detection of deep endometriosis when compared to previous studies. So what are we doing to further this? So at the moment, we currently have 2 prospective studies ongoing at GSTT. So one is one being run by us and forms the main basis of my MD, which is also looking at fertility. And a second is in conjunction with Esprit 2 as an ultrasound arm to that study being run out of Edinburgh. And that is it.
Thank you. Thank you very much, Frances. I see that Mr. Holland has joined us as well. Hi, Tom.
I'm trying to stop sharing. There we go.
Hi, everybody. I'm really
Hi.
sorry. I was having some technical trouble there.
Oh, okay. That's what I thought. That's what I thought. So, look, Frances, thank you very much, and congratulations to both of you and the rest of the team. I think this is a wonderful achievement. There are a few points that I wanted to mention and see what you think. One is just that I don't know. I'm just being maybe too technical here, but the sensitivity is 50%, but we have to always keep in mind that sensitivity is meaningful only in the context of the pre-test probability, meaning that a patient is sitting in your office with pain, you have no diagnosis. What are the chances that she has superficial endometriosis? And that probably is in the order of 20–30%. Nobody knows. 10% is the population risk, but by the time somebody's in your office, that probably doubles or triples. So a negative ultrasound scan in your hands wouldn't give her a 50% chance of having endometriosis. It probably will give her a 15% chance of having endometriosis. But, that may be semantics. So it's important to see what the pre-test probability is and then apply that 50% to it. Would you agree with that?
That's definitely very important. I think also you only work out the sensitivity afterwards. So it's not that if somebody's in front of you and they have a negative scan, they've got a 50% chance. It's that if somebody has superficial endometriosis, you've got a 50% chance of it being shown on the scan, mainly because it might be in a location that's more difficult to assess, like under the ovaries or in the UV fold, which we're not terribly good at the moment, or somewhere else.
No, I get that. The point I'm making is what the patient wants to know when she's sitting in front of you in the office, not having had the operation yet, is, doctor, you're telling me my ultrasound scan is negative for superficial endometriosis. How likely is it that I still have endometriosis? And to be able to answer that question, we need to then know what her pre-test probability of having endometriosis is.
Yeah, and that depends on what sort of clinic you're in. And the fact that she's come to you suggests that she's probably got a much higher chance than the general population, first of all, but also probably much higher than the population who would, say, be in a general gynae clinic where it's going to be much lower. And that's where you have to fall back on symptoms. And the only symptom that's really helpful in this context is dysgeusia. And if they have dysgeusia, then their chance is much higher. Things like dyspareunia on its own is actually a negative predictor. Is it? Yeah, if it's on its own, it's a negative predictor. You have to have dyspareunia and significant dysmenorrhea and so on and so forth. And that's on previous research that I've done. Dysgeusia was the only thing in this study that actually helped in terms of symptoms. But symptoms, if people give you a compelling story, I think we're compelled to offer them a laparoscopy, regardless of what your tests show, because if they've got a compelling story, they want to know either one way or the other normally. I think the thing about this study is that it's most useful for women that don't really want surgery but want an answer. The high specificity says that if we can see something there that's convincing for superficial endometriosis, then it is very likely to be true, and therefore they can make an informed decision about what they want to do, whether they want to have medical treatment or whether they want to have surgery. But for those women, that the certainty is very helpful to be able to say, yes, you do have endometriosis. It's not really bad. Surgery may help you. We hope it would, but there's no guarantee. But medical treatment probably is a more sensible approach, and if that works, great. So for those women, it's really, really helpful. Like you said, the women that is negative for, it's very difficult.
Yeah. Yeah. So I guess, Annette, this answers your question. Annette Reed had asked a question exactly on those lines, and I think you answered the question. I have another question about technical aspects of it. How much does the pain finding and the dynamic findings of the ultrasound scan help you in actually focusing in certain areas more than others? So when a patient goes, ow, will you then concentrate more on that area?
So other people have said that it should be tenderness guided. And certainly if you find a lesion that's sore, that's helpful. But essentially, it's very difficult to reproduce tenderness in these examinations. Often if you poke someone, they say, ow, and you poke somewhere else and they say, oh, that's not sore. When you come back to the original place, often it's not reproducible. We haven't tested it scientifically by roving the pelvis with the probe and saying, is this sore, is that sore, and trying to correlate that with then the findings. So I don't personally find tenderness to be particularly helpful unless I've found something. Certainly you can use it as a guide to look in more detail, but often it doesn't really correlate. Obviously, if you have deep endo, it's often tender, but then you're going to find it anyway because, you know, it's deep and it's fairly obvious. So does that answer your question?
Yeah, it does. It does. But I also wanted to highlight another general issue with all studies that look at operator-dependent techniques. And that is what your study is saying is not that the specificity of ultrasound, transvaginal ultrasound scan for picking up superficial endometriosis is 90-something%. It is saying that the specificity in the hands of Tom Holland is 97%, you know. So
yeah,
my
or Francis
question,
Bailey.
And Francis Bailey, yes. So my question is, how transferable are these techniques, and can we teach some, you know, a dumb person like me to do the same?
You're fishing for compliments, and I'm not going to fall for that. But so the point is, could you teach a sensible sonographer the technique for looking at these things? And I think the answer is yes. I don't think it's rocket science. I think it takes a little bit of effort and thought to try and work out these techniques. But what we're doing is not difficult. We're talking about basically putting the probe in the posterior fornix and then looking at the peritoneum. And once you know what you're looking for, it's actually not very difficult. So I think you could teach it to pretty much anybody in the same way that, you know, 15 years ago, we thought you couldn't see deep endo because nobody ever looked for it. And now lots of people see it very easily. And the same with ureters. You know, 10 years ago, we thought, oh, you can't see ureters on scan. And then Davos said, oh, actually, it's actually pretty easy. It's easier than finding the ovaries. And now many of the sonographers at Tommy's find ureters, find ureteric stones in the emergency gynae clinic. So all of these things, it takes somebody to just describe exactly how to do it. And then if they show people, I think it's relatively straightforward from then on. I don't personally think it's any more difficult than finding the ovaries. What do you think, Francis?
Yeah, I would agree. I mean, I had no scanning skills at all when I started in this clinic, and, you know, doing it once a month or so on the basis of also doing routine things like early pregnancy and emergency gynae scans. By about sort of 5 months in, I was very happy with looking at the Douglas peritoneum. I think if you've got someone who is already familiar with the anatomy, and the most important thing is actually someone who understands what's normal, it's actually very easy when you then look for it to see what is suddenly glaringly obvious, but you just haven't necessarily put your probe in that position before to even look to see it. Yeah.
And the reason that I think, you know, we've arrived at it is because, as Francis said, you know, I'm scoping many of these patients. So if I tell them I think you've got superficial endo, and then I scope them and they haven't, I'm only embarrassing myself. And, you know, that's okay. The patient will forgive me probably. Whereas if I say to somebody like you, Shaheen, oh, they've definitely got superficial endo, and then you look in and there's nothing there, you're going to think I'm an idiot. So I'm going to be much less likely to actually commit myself. And so there's a real benefit to having direct feedback as a sonographer and then surgeon, which has meant that it's given me the confidence to actually go looking for these small things. But, you know, even 6 years ago, I wouldn't have told anybody else about what I've seen. You know, these 2 millimeter little tiny nodules in the pouch, I would have said, I can see it, but I'm not going to comment on it because I don't want to be wrong. And I don't want people to stop referring to me for being wrong. Whereas if I'm operating myself, I'll make that commitment. And then it turned out that I was getting it right. And therefore you develop that confidence. So that's how it comes about initially. But then once that barrier has been broken, you say, well, 2 millimeters is actually quite big on a scan. Then you can then have the confidence to go and teach people. Does that make sense?
It does. And it also answers another one of the questions in the Q&A box from Mukit, that the cutoff for diameters for visualization. Would you put a number on it? What's the smallest lesion you could possibly see?
Well, I think 2 millimeters in thickness now, 1.5 to 2 millimeters is about the cutoff. I mean, anything less than 1 millimeter, you're really clutching. But the other
range was 1 millimeter was our smallest diameter that we measured.
Okay.
Yeah. But the other issue is, you know, we call it superficial, but there's a whole debate to be had around what actually is superficial, because we were using 5 millimeters as the cutoff, which is the kind of 35-year-old definition from Koenig's. But actually, you know, Andrew Horn and the rest of them at ESGE changed the definition away from 5 millimeters towards confined to the peritoneum, and they haven't really defined what they mean by that. They're just saying it's only peritoneal disease. And so there's a whole debate to be had around, do we change what we describe? Because 5 millimeters is quite deep, really. And so is there a new
but
definition?
I think the issue of 5 millimeter was that the people that actually came up with the 5 millimeter later on wrote to retract it, to say that we just made it up, and there was no scientific
basis.
It was just an arbitrary number. And of course, none of us will, before the time of ultrasound scan measurements, nobody during surgery would go and measure the depth of these lesions. So in a way, it makes sense. Just to wrap up the questions, Annette makes a point and agrees with you that, you know, we also had in a couple of weeks ago in the ESG Academy session the perfect match sonography and surgery for endometriosis, and the discussion around the pattern recognition and learning with repetition, which is exactly what you're saying. And LSPA is asking, do any of these lesions have Doppler signal? I doubt there will be any meaningful Doppler in the sizes that we're talking about.
There's no Doppler. So all of these lesions, when looked at, are then Doppler is then put over them, because they, by definition, they should not have any Doppler flow. So if there's Doppler flow, then it's vascularity that you're seeing on the grayscale.
And then the final question before we go back to our little articles, from Julia. Would it be a positive sign of superficial endometriosis if you have a diffuse thickening in the pouch of Douglas?
So what happens is that when you get inflammation, the subperitoneal fat gets thickened. So you get a thickened white line. The reason we didn't include that in this is because Dav was about to publish on that specific topic. And so I thought, seeing as I'd spoken to him, it was unfair to steal that idea. But you get a thickened white line of the subperitoneal fat with the chronic inflammation. In terms of a diffuse thickening of the peritoneum, I think you have to be careful about what you're describing, the superficial endometriosis tends to be discrete, like small areas with normal peritoneum next to it. So there are other things that can cause peritoneal disease, and I think you have to be quite careful that you're being specific for endo.
Well, thank you very much, and congratulations again. I think this is a brilliant paper and a very good results. We're certainly going to send you more patients to see if you can pick them up, and then we'll send you some feedback on those. You've been right so far, so we'll see.
Oh, thank you very much. I appreciate that, and I'm sorry for being late.
Don't worry.
I'm grateful for the invite. Thank you.
Not at all. Not at all. Okay. Bye for now.
Thanks.
So, Avril, it's you again. You're on mute.
Right, yes.
Oh,
Okay.
okay.
So this next paper is a paper looking at, again, complication rates, pain scores of with using a specific vascular sparing and nerve sparing bowel resection for deep endometriosis. Again, this is a retrospective single center study from Italy, and when they mean vascular sparing, they mean preserving the superior rectal artery by preserving the inferior mesenteric artery. And when they say nerve sparing, they mean preserving the inferior hypogastric nerve. So this is a retrospective study between 2019 to 2021. 61 patients were included in this study, and they were patients with nodules 3 centimeter or more following shaving, cases of multifocal disease, and also subocclusion of the bowel as well. Right, so let me move on to this. So baseline characteristics, obviously most of them would be ASRM 3 or 4 since they require segmental resections. Common symptoms, dysmenorrhea, dyspareunia, dyschezia as well. All the surgery was performed laparoscopically. They did have a high incidence of ileostomy, about 31% of ileostomy, and this was based on surgeon's judgment. And then in terms of intraoperative complication, they did not find any Clavin-Dindo grade 3 or grade 4 complications. Their most common complication was urinary dysfunction, which was managed with intermittent self-catheterization and all resolved after 45 days of a surgery. They followed up their patients for 6 months, and as you can see here on the VAS score of their pain symptoms, there was a significant improvement in the pain symptoms following surgery. So in conclusion, this technique shows a low complication rate and a good improvement of pain symptoms. Yep.
Okay. Mikey, Ben, any comments?
Yeah, quite a high, what was it, 20% of ileostomies?
Yes.
31.
31%, that's a lot.
The other interesting thing is how useless ASRM staging is, because they've done segmental resections in all of these patients, and half of them would count as stage 3.
Yeah.
So that just tells you how how this is not. I'm not sure what to think. It's interesting, but to me it reads, okay, we did 61 segmental resections and we didn't have any complications, which is great. Interesting though, because would you really count 30% ileostomy? It's not a complication, of course, but that means they need another operation to reverse it. How useful is an ileostomy? And I think that is another thing. The other very striking fact is, again, yet another Italian series of endometriosis patients, and look at that BMI. 22.9.
Yeah, 20 to 24.6.
Yes, that was the biggest patient they had. Okay. Well, an interesting one, and it also was interesting to see that they introduced nose technique to their armory, and that was since 2021. We're going to start doing that as well. Anything else?
No.
Yeah. The other thing is the duration of the surgery is also interesting. If you go back 350 minutes, that is what around 6 hours average,
Yeah.
and days of hospitalization 6 to 8
It
days.
is.
Okay. Yeah. All right. Thank you very much, Flo.
Do you think, Shaheen, do you think they have a cutoff that if your BMI is over 25, then you're not allowed surgery?
They probably do. I think we should stop doing that as well.
Yeah, that would reduce the waiting list significantly. I
It,
don't think we'd operate on
well,
anyone at Tommy's.
as in makes it zero.
Exactly.
No, 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 no. I take that back. I take that back. Okay. Next. But oh, the other thing, I wonder what you think of this, Tom, because we've been discussing this for some time now. Look at the days of catheterization. We keep seeing that from wonderful surgeons across the world, and I'm starting to question myself now. So self-catheterization in their group was 10%. Do you get 10% self-catheterization rate in your patient groups?
Yeah, I'm quite strict about post-void residuals.
Yeah.
And yeah, I do have quite a few patients failing TWOCs. And if they fail TWOC a second time after a week, then yeah, we do teach them intermittent self-catheterization. And normally, like in the findings here, normally they don't do it for very long. We say once it's below 50 mils on a couple of days, then just stop. And some patients last 2 days and some
And
patients last a couple of weeks.
what do you count as a fail TWOC? What residual do you accept?
I used less than 150 twice in hospital, and I'm quite strict about it. I mean, some people use, a third of the total volume. So if you pass 400 mils and you've got 200 left, they'd be happy. But I've always used 150. What do you use as a cutoff?
100 actually. But we do the same. We try again. If they fail once, we try again. We put the catheter in, leave it overnight, and try again. If they fail, what we do is not self-catheterization, and maybe you can tell me I should, but we send them home with a catheter for a week and then bring them back for a TWOC. That has happened. Avril will have the exact numbers. That has happened in around maybe 2 to 5% of our patients.
And if they fail the TWOC after a week, then what do you do?
That's the thing that we've just published our data actually accepted for publication on 1,116 patients. We've had one patient that ended up self-catheterizing for up to 3 months. So, and that's why I'm starting to question myself, because I hear from most of my colleagues that actually so I'm probably missing a lot of retention, but I'm still not sure how I'm missing it, because all our patients get a bladder scan before they go. All our patients will make sure they knock on our door if they're not emptying their bladder. But I realize that some of these will go into retention over the course of the year. But we're talking about the immediate post-op period. This is something to look at, I think.
Either you're very good at protecting their nerves, which I can believe, given that you're training with Passover, etc., or maybe your bladder scanner's under reading. And the only way to check that would be if they ever fail, with a bladder scan, when you put the catheter in, just check that your bladder scan and the post-void catheter is the same volume.
Yeah, I'm certainly going to do that, because we were Horace has just actually published on the topic just last week. We're going to invite him to come and be another featured article. Avril, do you remember what his numbers were? It was something around 30%
30%.
that will end up self-catheterizing, something like that.
It was 30, yeah.
Yeah, around 30%. So, you know, Horace is very good at protecting nerves. I'm sure you're very good at protecting nerves as well. I can't really put it down to that. It's something else. It's either, you know, we're missing it, or I don't know. That's bugging me now. All right, let's go to the final paper. We have 3 minutes. Flo, you're on the spot.
I'll make this quick. So this was published last year in Nature. Endometriosis increases the risk of gestational diabetes, a meta-analysis stratified by mode of conception, disease localization, and severity. So I thought this was interesting because there is growing interest in adverse pregnancy and neonatal outcomes associated with endometriosis. They are at increased risk of preterm delivery, hypertensive disorders, and small gestational age. But the link with gestational diabetes and endometriosis isn't still quite understood or appreciated yet. So the methods, this prism diagram shows how they found their papers. They used various search engines with eligibility criteria, generating 18 studies. Of these 18, 15 were cohort and 3 were case control studies. So moving quickly on to results. So this is a forest plot to show the risk of gestational diabetes in endometriosis patients compared to control patients. You can see the studies included with a heterogeneity of 50%, so pretty moderate, but overall there was a significant increase in risk with the endometriosis arm, with an odds ratio of 1.23, confidence intervals between 1 and 1.4. And then the study group then stratified and looked at different areas. In particular, they looked at the the means of conception. So moving on to the next slide, when they looked at the risk of gestational diabetes, depending whether it was a spontaneous conception or ART, interestingly, they showed that actually there wasn't a significant difference in risk, with an odds ratio of 0.97. Then they went on to look at the disease severity. So in the bottom forest plot, you can see that actually the risk of GDM in stage 3 to 4 on the ARSM scale compared to stage 1 to 2, there was a much greater risk in more severe forms of endometriosis with an odds ratio of 3.2. So main conclusions from this systematic review and meta-analysis. So they did convincingly show that GDM risk is increased in pregnancies with endometriosis compared to controls. And that main finding aligns with the consistent evidence that there is an increased risk of adverse pregnancy outcomes in pregnant women with endometriosis. And there was a sort of noteworthy sequence of progression showing that there was a greater risk of GDM with more severe stages of endometriosis. But it's the link between that which sort of remains controversial. And I think that really stems from the fact that a majority of endometriosis patients do suffer with infertility. And so then they seek ART, which probably is the main driver for these sort of findings. And actually this study group has suggested that it's this ART, which is the main confounder in interpreting the current research. It did briefly comment on etiology and why these women with endometriosis are more at risk of gestational diabetes. They suggested that it was actually the chronic inflammation that causes the hypoglycemia, and that is what's recognized in women with PCOS. So women with PCOS have a 3-time increased risk of gestational diabetes. And so clinically that impacts our practice, and we actually test these women for gestational diabetes. So this paper is suggesting with these findings, is it actually that we should be testing endometriosis patients for gestational diabetes, picking up their disease earlier, managing it better, and improving the maternal and neonatal outcomes? And that's you done.
Okay. Well, that's an interesting one. I couldn't really figure out what the relationship could be. Do you think now we've had now in Legendo, well, 13 sessions, and we've presented probably 4 or 5 articles that link different pregnancy outcomes to endometriosis. Do we now count endometriosis as a risk factor in obstetrics? Do people even ask the question, do you have endometriosis? And if they do they go out of the midwifery-led care? Should they? I don't know. I'm just asking.
I don't think so, Shaheen. I think there's more appetite for adenomyosis rather than endo when it comes to obstetrics. I think there's more trend of more ultrasound scans. I think people are realizing that there's a risk of IUGRs, placental dysfunctions with adeno. But I think as endometriosis goes, I think we at the stage where we are planning for safe delivery. So the only queries that we would get would be, is it safe to deliver this person vaginally, or does she need to have a cesarean section? For example, if there was a full thickness vaginal nodule or vaginectomy or segmental. That's my experience at least. But yeah, I don't do antenatal clinics, I guess. So I don't know. What do you think?
I don't know. I'm just reading a couple of comments. One is from S22 Ultra Milik Kartika. Is it possible that DMG, I think maybe gestational diabetes, yes, and endometriosis are in the same low level of vitamin D3? I don't know, above my expertise. I guess it's possible. I don't know. And Annette says the chronic inflammation suggestion is plausible. We'll try to find some supporting papers, but I agree. It's related to ART. So can you just, I missed that part, Flo. Did they show that the size of the effect is related to ART or not?
So they did 2 different things. First of all, they looked at the risk of GDM in only pregnancies that are conceived spontaneously, and they showed that there was an increased risk of GDM. Then they looked at a different population in women who only conceived by ART, and they showed that actually there wasn't a significant risk in GDM. So it is conflicting, but then they looked at it together and they compared the risk in with ART and with spontaneous, and then they showed that there wasn't a significance. So the fact that the risk of GDM persists in normal spontaneously conceived pregnancies would actually support the fact that it is the GDM, that it's the endometriosis that's causing the risk of increasing the risk of
not necessarily
GDM and not ART per se, because we know they say ART increases GDM, but is it the ART? It might be that it's actually the GDM.
Okay.
Sorry.
No, that's quite interesting. Let's just close. We're 5 minutes over time. First of all, to remind everyone that 6th of next month, there is the next Legendo. I'm glad that we've got the 13th one out of the way because I was worried something will go wrong. And the next one is going to be, the featured article is going to be my friend from Sydney, Danny Chu, who's going to present his technique for partial thickness discoid excision of rectovaginal endometriosis. Oh, we have the little Francis's girl. She's only 3 months. Welcome. Maybe she'll go into endometriosis. We're just telling.
She's not very happy.
Oh my God.
Oh, so cute.
So cute. Oh, well, thanks for sharing that to us. Well, that's the little girl. Your first appearance on the endometriosis platforms. More to come. So yeah, that's one. Please join us for that and spread the words. With the more, the merrier. And if you want to help, please join us. And finally, another thank you to the whole of the team, because it actually takes a lot of work for the team to go sift through lots of, can I say that on air? There's lots of nonsense on that gets published. So sifting through good papers and picking up the things that are worthy of attention is not an easy task. And so thank you for doing that. And I hope I will see you all on the 6th of next month.